My presentation for today is a PCI in a lesion with a high calcium content. Lesions with high calcium content, they are probably the most challenging ones to handle in the cath lab, and they adversely impact both the short as well as long-term outcomes of the percutaneous coronary intervention. They are challenging to cross with the standard devices, and they are less likely to respond to our normal balloon dilatations. Those patients who have lesions with high calcium content, they are less likely to receive complete revascularization, and they are more likely, therefore, to die subsequently. Starting with my case history, she is a 72-year-old woman who is a known case of systemic hypertension, and she presented to us with complaints of chest discomfort at rest since past 20 days, and there was one episode of transient loss of consciousness also. Physical exam was unremarkable except for a right carotid artery buoy. ECG showed sinus rhythm with the left bundle branch block. Echo showed regional wall motion abnormality of the anterior wall with mild LV dysfunction. And there was a past history of road traffic accident, and she had a vertebral injury, and due to that, her activities were limited. This is the coronary angiogram, which showed a minor disease in the distal left main, and LAD had a proximal to mid LAD had a long calcific disease. RCA was unremarkable. There was minor disease distally only. So this lady, we took her up and we wired with a regular 014 workhorse wire. After that, we tried crossing a 20 into 10 balloon. It didn't cross. Then we downgraded our balloon to 105, and this balloon also didn't cross. And in an attempt to dilate, it got ruptured only at 5 atmospheres. Probably the balloon was not de-aired properly, and after that, patient had a slow flow. Her blood pressure fell down. There was a hypotension as well as bradycardia. We gave it atropine intravenous, and intracoronary vasodilators were given. After that, the flow improved. So at this point, we decided that she needed some kind of a calcium modification therapy. So at present, the technologies which are available to us can be broadly classified into ablation techniques or balloon-based techniques. This is the table which show different ablation as well as balloon-based techniques which are available. In ablation techniques, we have rotational atherectomy, orbital atherectomy, excimer laser, whereas balloon-based techniques, we have cutting balloon, scoring balloon, super high pressure, OPN-NC balloon, or lithoplasty or lithotripsy balloons. As far as ablative techniques are concerned, in last 10 to 15 years, there have been a paradigm shift in the as far as their functionality is concerned, and right now the fundamental is to modify the plaque rather than debulk the plaque, and this modification is achieved by selective action on the hard calcified component of the plaque. Calcium cracks and dissection flaps, they are the most common findings after ablative techniques, and they are associated with improved expansion of the stent. And in less frequently, we can see actual evidence of tissue ablation or tissue removal in the form of craters, tunnels, or gutters. So as far as ablative techniques are concerned, right now the fundamental is to only achieve plaque modification with a as smaller size ablative device as possible. So we decided to use a rotational atherectomy in this patient, and we don't have a rotational atherectomy at our center. So we have to call that, and it was planned after 3 days. And again, LED was wired with the 014 workhorse wire, and then with the help of microcatheter, it was changed to the rota floppy wire. Then we started with a 125 mm burr, since our 1 mm balloon also didn't cross. So initially, the burr has a problem even in crossing the proximal part of the calcific lesion. And with difficulty, it crossed the initial part of the lesion, but again at the mid LAD, we can see a dense calcium, and burr, it was great difficulty for burr to cross that part of the lesion. So in total, we used a 2 minutes 5 seconds of 1.25 mm rota burr at 170 RPM, and each run was for around 25 seconds. Then finally the middle LED lesion gave away and the burr crossed, and then in the last we gave a final polish run. This is the angiogram immediately after the rotational atherectomy. Still, the mid LED part was not up to the mark dilated. So we used NC balloon 2.5 into 10 mm. And after that, we did a IVUS for this patient. We can see a fibrous plaque in the mid distal LED. And as we come towards middle part, mid LED, we can see a dense 360-degree arc of a superficial calcium there. And this extended till the proximal part of the LED, and there was some component going into the distal left main also. This is the post rota and NC IVUS, and we can see that there is a dense calcium around through 360 degrees, and on the right hand side we can see the calcium cracks which have been produced after the rotational atherectomy. After that, since the calcium arc was 360 degrees, so we decided to use a 2.5 into 10 mm cutting balloon, and it was used at 6 to 8 atmospheres in the middle and the proximal part of the LED. This was the angiogram post cutting balloon. We can see a dissection in the proximal middle LED part, and then we decided to stent the mid distal LED with the 275 into 32 mm everolimus eluting stent. And after that, the osteoproximal LED was stented with the 3 into 23 mm everolimus eluting stent. After that, we post dilated with the 3 into 10 mm NC balloon at 18 to 26 atmospheres from distal to middle to the proximal part of the stent. And this is the final result after that. This was the post stenting IVUS runs, which showed a good MSA in the proximal as well as distal part of the stent. Just a few words about the lesions with high calcium content. And if suppose we have a lesions with high calcium content on coronary angiograms and they are balloon uncrossable, as was the case in our patient, so we can try crossing with the microcatheter. If it crosses, then we have an option of changing the wire to the rotational atherectomy or orbital atherectomy. And if it didn't cross, even the microcatheter didn't cross, then we can try direct wiring with a rota or a Viper wire. And if that fails, we can go ahead with the laser. And after atherectomy ablative techniques, we can see if there is optimal balloon expansion. We can directly go for stenting. If there is still not optimal balloon expansion, we can try lithoplasty or lithotripsy balloons. Whereas on the other part, if the lesion is balloon crossable, then we should do a intravascular imaging, OCT or IVUS. And usually OCT is preferable because it gives us the length as well as thickness of the calcium. And if calcium arc is more than 180 degrees, length is more than 5 mm and thickness is more than 0.5 mm, then we should look whether the calcium is superficial or deep. If it is a deep calcium, then probably lithoplasty or lithotripsy balloon is preferable. If superficial calcium, we can try again ablative techniques, either rota or orbital. And suppose if none of these features are there, we can try our normal non-compliant balloons or even cutting or scoring balloons. Again, similar, if we achieve optimal balloon expansion, we can go ahead direct with the stenting, or if it's not achieved, we can try lithoplasty or lithotripsy balloons. Rotational atherectomy may still represent the only available technique in many centers for the lesions with high calcium content that cannot be crossed with a balloon. Clinical trials, although have failed to prove a consistent long-term benefit in terms of restenosis and major adverse cardiac events. The Rotaxis trial, which compared PCI with rotational atherectomy and drug-eluting stent versus standard PCI with DES, in that 240 patients were there with moderate to severe calcification. Rotational atherectomy, it was associated with acute luminal gain, but there was also larger instant late lumen loss at 9 months with a neutral effect on the restenosis. On the other hand, Prepare Calc trial, around 200 patients with severe calcific coronary artery disease, they were taken, and rotational atherectomy was compared with cutting or scoring balloon angioplasty. RA was superior in terms of procedural success compared with the strategy with modified balloons, and it was not associated with excessive late luminal loss as was in the previous trial. In Rotaxis, more than half of the lesions in both the arms of the study only had a moderate degree of calcifications, and late lumen loss at 9 months could have been related to the use of first-generation drug-eluting stents.
I think rather than these data, we can have a discussion of the case. That's more important.
Thank you.
So thanks, Sahil. This was again a good, wonderful case. Kunal is here, I think. Dr. Kunal. So can you take over with the discussion part?
That was a wonderful case done by Dr. Sahil. I must congratulate him first of all. In fact, he really showed us how to use plaque modification imaging in a case with a balloon uncrossable lesion. The only thing which I want to ask him, once you had done the rotablation and a NC balloon after that, there were visible cracks on the calcium on IVUS. So why did you went ahead with a cutting balloon in? Because you had already achieved an optimal expansion with the balloons and very optimal cracks in the calcium. So probably if you could have stented at that moment and then post dilated, I agree that it is useful, but what was the special, what the rationale used by you for cutting balloon at that moment?
Yeah, when we saw the MLA after that, although cracks were there, but we were not very happy with the MLA achieved after that. And we thought that it's a 360-degree of arc. And actually, I wanted to use a bigger burr, but due to financial constraints, we were not able to use that. So after stenting, if suppose my stent expansion would have been bad, then I would have been in a major difficulty again. Then the only option left would have been a lithoplasty or lithotripsy balloon or OP and NC balloons. Again, that would have cost me extra this thing. And cutting balloon and was already discussed with the patient previously. So I thought preparing the bed would be better rather than to stent and then do post NC and OP and NC and all those
Very
things.
appropriate. Great.
Yeah. So Sahil, wonderful case. Now I'll extend the same question which Kunal was asking. So one, you could have chosen 1.5 burr to start with. That would have been maybe the first choice burr because the vessel looked quite 3+. You know, what size of stent did you choose once you stented that?
The three distal was 275, proximal was 3,
So
and I
it was
dilated.
clearly a 3 vessel, and 1.5 bar to start with could have been a very good bar. But I agree, for the beginners, 1.25 bar should be the first bar, and then they can step up. That is always better. While you are doing to and fro movements, those were very good, appropriate movements, and this is the way to actually cut the calcified lesion with the rota bar. Be very patient. Don't try to push.
Yes.
Don't try to push hard. This is the mantra for using a rota burr. And also, these packing to and fro movements are very important. Take your time. You know, after 4 or 5 passes, take a break. You know, otherwise breadies and other stuff would start happening. Take a break, go again, keep trying. At times, it takes time for very densely calcified lesions, to surpass those lesions, it takes time. But one more thing. Now let's discuss, if this burr do not cross the lesion, then what's the next step?
Then they have written we should increase the guide support, and we can try it probably then taking again a smaller balloon NC, and we can try taking that, like Nick Nano and all those things are there.
No, balloon was actually only 1 millimeter balloon went prior to this, and I'm saying bird did not cross. So if the bird is not crossing, the next step is the speed of rota, the rotational movements, increase that. That is the very next step. If you are at 180,000, increase it to 2 lakhs. You know,
Okay.
so beyond 2 lakhs, people go beyond 2 lakhs also, but it generates a lot of heat, you know, if you use those rotational movements. And beware, once you are using a high speed rota 2 or beyond, your wire should be specifically into the main vessel, not into the side branch. It wire also rotates with that, so that may complicate the scenario. It may get stuck into the endothelium. And then wire should be quite distal. At the distal point, it should not be, because every time you tend to push the rota burr slightly with the packing movement, the wire tends to come back. So these are the things one has to keep in mind while using rota. It's a very good modality. We use it very frequently. And nowadays, poor man's rota is IVL. If the balloon goes, if you can dilate with 2.5, then get a IVL balloon that also cracks the calcium. But there are certain circumstances where there is an absolute protruding calcium into the lumen, rota has no match. Then see, like in this case of Sahil's procedure, clearly balloon was not going. So it has to be answered with rota, not IVL. But yes, if after rota there is still a residual thing, you can use a combination, that is a rota tripsy. Then you can use IVL later on after debulking with rota. So these are some of the tips with rota. Be very careful with tortuous vessels, but in such like straight vessels, calcified vessels, rota is a boon. You know, it's quite a positive thing to give a way into the coronaries, and then you can stent those vessels. Otherwise, very well done, Sahil. Very well done case.
I will like to ask one thing, that if my 1 mm balloon ruptured at 5 atmospheres, then we can start with even 1.5 mm burr.
Yes, 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 yes. So there are normally the dictum is that don't balloon if you are deciding to burr.
Yes.
You know, if your wire goes, you know, there are challenges. Sometimes rota wire is a very flimsy wire. You know, it's not the first wire which would go with a very difficult total occlusion lesions. So you have to have a normal wire, or then a long catheter there, the exchange catheter over which the wire is exchanged. This is the way to have a rota wire parked into a distal segment and then do the rota. But if you are clearly decided that you are going ahead with rota, don't balloon. That will create some dissected flaps, and rota may create problem. But at times, this is not the decision to start with. Then we dilate, and then we see that nothing is crossing, balloons are bursting, then take rota. But if it is still a small segment of that coronaries where you have done the balloon dilatation, you can still use rota.
Yes,
But if there are visible dissected flaps, try to avoid it in that sitting.
yes. Okay.
Okay,
For the
but
benefit,
well done, Sahil.
so just for the
Yeah.
benefit of everyone, sir, can you please elaborate how do we select the size of rota bar upfront? Like
Yeah.
when we should use 1.25, when we should use
Yeah,
1.5. That would be really useful, sir.
So I tell you, from the word go, one who's starting to use rota, the beginners, first 10 to 20 cases, do it with only 1.25 bar. Don't use 1.5 bar. But otherwise, the guidelines are the ratio, the bar to vessel size ratio should be 0.7 or lesser. It should not be beyond 0.7. So with a 3 millimeter artery, 1.5 is 0.5, so we are okay. With a 3.5 millimeter artery, clearly go ahead with 1.5. Don't even think of 1.25. But from the experience point of view, I'm saying first 10 cases, do it with 1.25. You know, get your reflexes made for the rota ablation usage, the packing movements, the to and fro movements. You have to look at the two paddles, one the fluoro paddle and the other the paddle for the rota ablation. So these are some of the movements where you need to develop your reflexes. That is the idea of saying that 1.25 is relatively more safer bar initially. Once your reflexes are made, it's fine. We use rota, we suddenly decide in the cath lab, call upon rota and do it in 10-15 minutes. So it's a extempore decisions. We have done a huge number of cases like this. So that's a separate story. But beginners, 1.25, 10 to 15 cases, and then if it's a 3 millimeter vessel, 1.5.